In this slide, we will go over care for individual with mobility needs. Let's go over introduction first. It is important for direct care staff person to follow infection control procedures to prevent illnesses. Of equal importance is taking steps to assist a resident to be as mobile as possible. Mobility gives people the opportunity to socialize, be active, and independent. If mobility becomes limited, a person's opportunities shrink and choices are reduced. Serious complications can result from long periods of limited mobility. While the thought of being less active may sound very soothing, it can lead to many complications that can cause problems in almost every major body system. Immobility can have the following effects: difficulty breathing and inability to expand one's lungs. The heart works harder to pump blood through a body laying flat. Possible problems with blood circulations are swelling, blood pooling in the legs, decreases in blood pressure, and increased risk of blood clots. Pressure sores develop quickly because the oxygen supply is reduced and pressure is increased. Muscles weaken and deteriorate from lack of use. If a person is in a flat position for a long time, urine does not fully drain out of the bladder. A person's appetite may decrease because they are less active or bored. Dehydration may become a problem as well. Mental health problems like depressions become more common. To help residents with mobility needs avoid these health risks, you can encourage them to be as active as possible, letting them do tasks, no matter how small, that they are able to do it safely. Pressure sores. Pressure sores, more commonly called bed sores, develop when there is constant pressure on an area of skin for a long time. This pressure squeezes tiny blood vessels that supply the skin with nutrients and oxygen. If starved for too long, the tissue dies and pressure sore forms. Anyone confined to a bed, a chair, or a wheelchair is at risk of getting pressure sores. Pressure sores often occur when the lower back and buttocks and on bony protruding areas such as shoulders, hips, knees, heels, and ankles. In the first stage of pressure sore, it will look like a red or dark patch. If it gets worse, the skin blisters. Dead skin will ultimately infect underlying tissues, bones, and joints. It takes as little as 2 hours of constant pressure to trigger skin damage. Damage can get worse by rubbing or having excess moisture on the skin. The surface damage you see is just the beginning. The real damage is under the skin. Always report any skin changes to your supervisor for assessment. Several risk factors increase a person's chances for developing pressure sores. Number one, age. The majority of pressure sores occurs in people over the age of 70 because skin is thinner, making them more susceptible to damage from minor pressure. Number two, malnutrition and dehydration. Number three, immobility. Number four, incontinence. When skin stays wet, for example, from urine, This can lead to pressure sores because wet skin is more likely to break down. Number 5 is poor mental condition. A person with certain types of mental impairment may be less likely to know or be able to communicate that a pressure sore is forming and take action to prevent or care for the sore. Some of the guidelines to prevent pressure sores include: number 1, avoid lying directly on the hip bones. Number 2, support the legs. Number 3, keep knees and ankles from touching by using small pillow or pads. Number 4, avoid raising the head more than 30 degrees so the person doesn't slide down the risk friction injuries. Number 5, use a pressure reducing mattress or bed. Number 6, daily skin inspection are an essential part of prevention, paying particular attention to bony areas, minimize skin exposure to secretions such as incontinence and perspiration. Provide adequate intake of fluid, protein, calories to aid against sores. Drink plenty of water. Okay, now let's talk about incontinence. What is incontinence? It is a loss of bowel and bladder control. There are two types of incontinence: fecal and urinary. Fecal incontinence is an involuntary bowel movement. Fecal infection, diarrhea, and some endocrine disorder such as hyperthyroidism may underlie incontinence. Depression, stroke, dementia, and other neurological problems may interfere with messages about the urge to defecate or ability to wait until a toilet. Urinary incontinence is the involuntary leakage of urine, regardless of the amount. Incontinence is a time consuming and expensive problem. You can help lessen the problem in the following ways. Number 1, you can affirm the resident's sense of dignity. When an accident occurs, offer your assistance by saying, for example, "Let me help you freshen up." Use the term adult brief, not diapers, which is demeaning. Protect the resident from skin breakdown and poor hygiene. Help, help keep the resident's skin clean and dry. When a resident who has had an accident requires your assistance, wear disposable gloves, use soap and warm water, rinse and pat the skin dry, place clean padding under the buttocks if the person uses incontinence pads. Follow the home's procedure for disposal of soiled articles. Wash your hand before and after assist.